That how this procedure is done. So I have two videos, 10 minutes each. The first one will be on the non-cultured epidermal cell suspension, and the second one will be on the follicular grafting for vitiligo. So I will be demonstrating the every step in this video, and I hope everyone will clearly understand it, and I will also engage the audience with the various variations in this procedure. So first one is the non-cultured epidermal cell suspension transfer video. Graft harvesting is done with the help of sliver sander, or it can also be done with the help of Humby's milk. And then the graft is transferred after the clearing with postpaid buffer saline solution. The graft is transferred to the trypsin 0.25% medium. The action of trypsin is to separate the epithelium from the dermis. Now this can be done in various ways. As you can see, this was done in the test tube. It can also be done in the petri dish. And then the graft is incubated for 45 minutes at 37 degrees Celsius. Meanwhile, the donor area is dressed. We can take the utilization of this time for dressing the donor area, and then we will prepare the recipient area. So, what are the variations in harvesting the graft? The harvesting can be done with the help of local anesthesia in the form of xylocaine infiltration, or it can also be done just with the help of topical creams. What is the advantage of topical creams? It can reduce the infiltrative anesthesia amount, so we can cover a larger amounts of recipient areas. Now, another advantage of topical anesthesia, the patient doesn't have to take injections, but some patients are more uncomfortable with the procedure. In these patients, we have to give infiltrative anesthesia. And what are the advantages of topical creams? The topical creams, it just give a superficial edema on the donor area, so that we can ascertain this is the donor area, and the epidermis gets very easily separated. Now what is shown in the video is the recipient area preparation. This is done with the help of motor dermabrader, and we have to take care that a very superficial epidermis is dermabraded. What is the difference in the superficial dermabrasion and a deep dermabrasion? In the superficial dermabrasion, very fine pinpoint bleeding will be there, but in the deep dermabrasion, a bit more bleeding will be there. And what happens is that when we apply the melanocyte transplant solution, that is the final pellet which is formed, it will get diluted with the patient's blood, and our result will be compromised. So this step is very important, that the dermabrasion is done very superficially. And there are various sites which are hyperkeratotic, like previously when we have to use the medications, then with the help of melanocyte ointments, topical soralins, and with the help of phototherapy also, topical phototherapy or the systemic phototherapy, the recipient sites get hyperkeratotic. And these hyperkeratotic lesions are very difficult to treat. That's why this procedure is very good for these stable vitiligo patients. And but the important thing is one has to use keratolytic creams before this procedure. The patient is advised keratolytic, maybe in the form of urea. He can apply those creams for around 1 month, so that the keratolytic layer goes off, and then we can perform the procedure, so that only a superficial layer gets dermabrated. Because if the layer is hyperkeratotic, the whole layer goes off in 1 month. We can't take the superficial layer out, and in those cases, when the whole layer goes out, the dermabrated area becomes very deep. As you can see in this patient, there are striae distensia, stretch marks over the recipient area. These are also some abrasions on the results. These produce some results to a less extent. Our results gets compromised to some extent in these areas. So meanwhile, our donor skin graft is being incubated for 45 minutes. We prepare the recipient area. For recipient area, we have to do it fast. We can do with the motor dermabrader, or we can also do with the manual dermabrader. Now the graft is trypsinized and now we are transferring it into the petri dish. So as you can see, appreciate, I think the graft has now a glazed appearance. This is because of the trypsin effect. The graft is glazed, and now I would be separating the epidermis from the dermis, but before it we have to neutralize the action of trypsin. What is the need to neutralize the action of trypsin? Because trypsin can damage the melanocytes, but there are various ways by the action of trypsin gets neutralized. First, the simplest way is to mix the phosphate of our saline solution. Previously, we were using anti-trypsin solution for the same to neutralize the action of trypsin, but nowadays, as the results are not compromised, we are using phosphate of our saline. And another theory is that the patient's own serum also deactivates the action of trypsin. So even now we can also transplant these cells directly without neutralizing the trypsin action. So the excess phosphate of our saline solution is now discarded with the help of micropipette. And I am transferring this extra phosphate of our saline solution to the different petri dish, and then I will be separating the epidermis from the dermis. There are various schools of thought on the epidermal-dermal separation. Like, it was said that dermis has no role in the melanocyte transfer or the epidermal cell suspension transfer process. But with the recent research, and I think it is from the PGI Chandigarh, that the dermal cells has a very important role in the proliferation and development and the perpetuation of melanocytes. So it is very important to mix the dermal component with the final melanocyte pellet which is formed. So as you can see, the superficial layer of the dermis is very easily separated, and then we are just extracting the melanocyte cells from the layer. So it can also be done with the help of blunt forceps, and the graft just gets tear off, and you have to cut into the small pieces without damaging the melanocyte cells, and it forms a paste-like thing. We can also add 2 to 5 drops of Dalbecos modified Eagle's medium in this, which will act as a medium for the growth of melanocytes. And this is the final solution which I have got after the epidermal-dermal separation. Then after transfer to the centrifuge tube, and then Dalbecos modified Eagle medium is now poured into the centrifuge tube. It is mixed with the tissue, and now this centrifuge tube will be kept into the centrifuge. The centrifuge we do is for 5 minutes at a rotation of 2000 RPM. The rotation RPM of centrifuge is very important. Why? Because if we do at a higher speed, then the melanocytes can get killed, and if we do at a lesser speed, it will not get separated. So as you can see, now I am discarding the extra DMEM medium, that is Dalbecos modified Eagle medium. I would be discarding the extra solution and would be just taking the final melanocyte pellet which is formed at the base of the pipette. Meanwhile, I will also discuss the advantages of this procedure. The advantage of this procedure, like 5 to 6 years back, I was doing thin thierce grafting, large thin thierce grafting. Even just today morning, the Facebook app has prompted me the procedure which I have done 4 years back, and in which I was covering around 150 to 200 square centimeters area with large 5 to 10 centimeter thick grafts. But nowadays, we have just stopped doing that and completely shifted to this very good procedure, non-cultured epidermal cell suspension. And the advantage is it can cover 5 to 6 times more area with the same amount of the donor area. If the area is confluent, means it is a single patch or 2 patches, it can cover around 7 to 8 times. If the lesions are dispersed and discrete, then it can cover around 4 to 6 times of the recipient area. So as you can see, I have I have applied the final melanocyte pellet on the recipient area. I would also like to emphasize that we don't add hydroxypropyl methyl solution in the final melanocyte pellet form, because somehow I don't think it is so much watery that we have to add up the hydroxypropyl methyl solution, but it can be added. It can be an adjunctive, at least for the newcomers, because if the solution is very liquid, then it can just very easily drip away. So it can be added, hydroxypropyl methyl solution can be added, and final solution which is formed is somewhere around 0.2 to 0.5 ml. And after the application of the final melanocyte pellet form, we do the dressing. We use the collagen sheet in the form of new skin F, that is a fish collagen sheet. And what is the advantage of this sheet is it acts as a medium for the melanocyte development. Secondary infections are reduced, and we don't have to, like in the previously around 4 years back, I was using alcohol dressings. But the main problem is that alcohol dressings are that they are melanotoxic. They kill the melanocytes, and during dressing only a significant proportion of melanocyte gets killed, and it can hamper our results. So after that, I have shifted to this new skin collagen, new skin F collagen sheets, and now it is giving very good results. And after the application of collagen sheets, it is dressed with a normal dressing with a gauze, and the patient can go home. We usually give the dressings for 5 to 7 days. The patient is given systemic antibiotics and painkillers, and is advised a bed rest for 7 days, though he can do his daily routine. But apart from that, we advise patient to take bed rest for 7 days, though a strict bed rest is only advised for the initial 72 hours, because it is said that the melanocyte fixation takes place in the initial 48 to 72 hours. So it is very important, mobility is very important. So this was the first video which I have shown